But unfortunately, about half the people, because I've had a lot of have big ulcers and there's no pain. So I'm telling you one thing, he's got diffuse artery disease, and I don't know how to fix it easily, if at all. Number two, I'm saying that he has kidney dysfunction that fortunately isn't off the tracks, but is a huge impediment because I can't ethically tie him down and say, I don't care if you don't want dialysis, I'm going to give it to you, sir. I can't do that.
We'll do that.
We can.
No, you can't. But, and that's good. We got some merit, that's good. So that's our second problem. Our third problem is this anemia, and is there an ulcer brewing? And then the fourth problem is his mind, which is good, but not great. And it's really showing its weaknesses lately. Today, yesterday, and the day before. And I don't think I'm screwing him with Valium or any other medicine. It's just, he's sick in the hospital. And so his mild cognitive, that's, only a technical term, his cognitive dysfunction is really showing itself. And my worry to you is that I have a guy over at Regional that has mild cognitive dysfunction. The family all said, you're going to go to surgery. And he goes, oh, okay. And now he's tied down in bed like an animal, totally out of his head, and his heart rate's racing because he's scared. He doesn't know anybody. And that's a terrible position to put us in, the nurses in, the surgeon in, because we go, yeah, we fixed the heart. And the guy goes, who are you?
So you're saying regardless of whether it's stent or bypass, there's going to be the risk that his cognitive ability...
No, the stenting won't make his cognitive dysfunction worse.
What is the difference? What?
The bypass is a pump where all your blood goes through this machine, and it creates a lot of little
things.
clots.
Yeah.
The old joke was the Secretary of Defense, Caspar Weinberger, went to bypass surgery, and they go, well, he was never the same after that. But when you have mild, or moderate dysfunction, this other guy, he was worse than your relative here, but he is totally, in trouble.
And that won't come back? Probably.
It depends. It depends. When it doesn't go back, then you really feel bad. But even now, we're like, oh, how do I treat him?
Yeah.
You tie him down and you sedate the heck out of him. That's really bad for open heart surgery in an old person. They get pneumonias, they get breakdowns. So that's where, but that aside, even if he had a great brain and he had kidney dysfunction and goes, I've talked about this, I've thought about it, I just don't want dialysis 3 times a week, 4 hours a day. I don't want it. Then the surgeon says, I will not operate on a guy and do all this work and have a 50-50 chance to go to dialysis and have him die because he won't be dialyzed. I won't do it. So I don't blame the surgeon for saying that. At the same time, the stenting is extensive. That's back to Dr. Bielbig saying, what's his primary problem? He has diffuse atherosclerosis. And so you gotta use little diamond bit rotors, and you gotta do lots of stenting with lots of dye in order to see where you can stent multiple times. And then for sure you're gonna kill his kidneys, or at least a 50-50 chance. And I'm not willing to again say, man, I'm in a tough corner. Here, somebody else have the problem. You go ahead and kill his kidneys and then have him die of kidney failure. Now, the only glimmer of positiveness out of all of this bad news is I can't predict the future. And I honestly realize that, both good and bad. So even though we're all really worried, because there's the data, there's the symptoms, like I told you, the guy that I said, you must go to surgery or else you're going to die, for a couple of years just kept coming back to me, showing me how stupid I was. And that he had arteries equally as bad. And so we need to see how he's going to do. His kidneys and his bleeding and his blood pressure and his pulse. And we're not going to make any quick decisions, but if we go forward medically, we're waiting for bad news to happen. But we know we don't really have any alternatives other than to just pray and try to do our medicine. And once in a while, they do fine. But we shouldn't prepare for that, only. We should prepare for the worst, which is recurrent heart attacks, heart failure, death, all this stuff, and say, well, what are we going to do? What I would recommend is, that he strongly consider not being hooked to machine and unconscious at the end, because it's not really good for him ethically. So I would say, do your best, 100%, Dr. Krieger and all your team. But if I do stop breathing and my heart stops, that's it. That's a good way to go, as opposed to hooked to a machine. But that's up to him to think about.
We already did that.
Well, okay, but he can change his mind anytime. He doesn't have to listen to me. Tomorrow he can say, I want this. And that's back to America. He gets to choose, which is good. in many ways, because you don't want to be bullied by some doc or nurse or family or anybody. You would say, no, I've thought about it. And in many ways, he's the exception where he's talked to David Jackson, he's talked to a nephrologist, and he's kind of looked at his body wearing out, and he kind of has made some decisions. So it's not a matter of, we all know people like this. They absolutely don't talk about diet. They absolutely don't talk about anything. They go, I haven't talked about it. The spouse says, I've been married 50 years. We never talk about it. And now they're unconscious and they don't know what to do. They don't want to play God. So I'm glad he's talked about it. I really am. I'm not being facetious at all. So let's wait and see how he does. Because nobody is willing, and I'm not willing to force them to do their thing while his brain and his kidneys and his blood count are all in play. Now, yesterday I had a different treatment angle because both the surgeon and the balloon guy